Looks like we have successfully arrived in our breakout room. So already we're ahead of the game, and it looks like we have everyone who we're expecting. So I'm thrilled to be able to moderate this discussion. I think we have our work cut out for us because our topic could not be more vast. And so I will do our best, my best, to sort of keep the group in both brainstorming mode, but also trying to make sure that we do sort of stay within our swim lane. So we have 4 guiding questions that we're going to spend sort of about 10 to 15 minutes each on, though I'll sort of see how the discussion goes and try to step in if needed. I think it's helpful for people to use the hand raise function, and I'll try to keep track of who has their hand raised and call on you in that order. I think the chat is always also helpful for additional ideas or things that you want to share, but maybe sort of can't figure out how to insert into the conversation. So I welcome use of the chat. We have a recorder and a reporter. And so let's see, I think Kathy, you are our reporter, is that right? Okay, so she has the hard job of summarizing all the content back out to the group in the subsequent session. And then our reporter is?
Hi, this is Asia. I'll be recording and taking notes.
Perfect, okay. So Kathy and Asia, to the extent you need to back channel to make sure that the recording is going to allow you, Kathy, to have what you need, or you maybe obviously just can take your own notes. Okay, so again, so any other logistics or questions? Maybe we can just do like a speed round of introductions. We have so little time, but I would love I think it's so helpful before we dive in for people just to say who they are. And so I got to be introduced already, so I'll just call on people, and again, just sort of really quick name and where you come from. So I'm just gonna go in the order of the little Hollywood squares on my screen. So Eva.
Good morning, I'm Eva Powell. I'm the Associate Director of Clinical Innovation at the Alliance of Community Health Plans. We're an association of community-based and regional health plans that are nonprofit and provider aligned.
Terrific. And Kathy.
Oh, I think you're on mute, Kathy.
Me. There we go. Kathy
Yep,
Blake. I'm AMA's Vice President for Healthcare Quality, and I'm in the strategic focus area that is really addressing obstacles that interfere with patient care, and specifically hoping to result in greater professional satisfaction and practice sustainability.
Wonderful. All right, we'll do Peter, then Eric, then Beverly, then Laura, just so you know when to prepare to unmute. So Peter.
Yeah.
Hi, Peter MB, President and CEO of the Regenstrief Institute and professor at Indiana University School of Medicine here. Great to be with you.
Terrific. Yesterday you got a new last name, Embry.
Yes, there was a lot of that, yeah. I'm used to it.
I'm sure you've heard it before. Okay, great. Eric.
Also with a difficult last name, Eric Gasho, Vice President of Policy and Government Affairs at the National Health Council. We are a membership organization based in Washington, D.C., predominantly patient advocacy organizations, but we're multi-stakeholder and work on health policies that impact all people with chronic diseases and disabilities and their family caregivers.
Great, wonderful. Beverly.
I'm Bev Johnson. I'm President and CEO of the Institute for Patient and Family Centered Care, and located in Bethesda, Maryland, but we work all across North America and beyond. And everything we do is in partnership with patients and families to bring about change and improvement.
Great. Laura.
Hi, good morning, everyone. And I am one of those PCORI observers that Dr. Cook mentioned earlier. So I am with PCORI. I am the Interim Chief for Program Support and Information Management for our award programs, as well as a Senior Advisor directly to Dr. Cook, working on our strategic planning, among other big projects. So thank you all for participating this morning.
Great, terrific. And Asia, you didn't really get a chance to introduce yourself. Do you want to?
Yes, hi everyone. I'm Asia, and I'm a research associate with the National Academy of Medicine Leadership Consortium.
Terrific. Okay, I'll just know, I know they said to turn off your video when you're not speaking, but I think it's a small enough group that everyone should feel free to keep their videos on. I just, you know, anyway, so I think that feels a little more comfortable, at least for me, though do whatever's comfortable for you. Okay, so let me just remind you of our 4 questions. So it's, are there additional concepts, topics, or key trends to consider? What are the potential disruptors and opportunities on the horizon in this topic area? What are the major challenges and obstacles to advancing progress related to this topic? And what would it take for this topic to have a measurable and positive impact on health and healthcare in the next 5 years? So again, 4 very broad questions, but I think it is a helpful place to start to sort of say, you know, what additional concepts, topics, or trends weren't addressed yesterday that you think are important to throw out there. And I'll just say that, you know, I mean, Dr. Denny's talk, you know, understandably focused on all of us and sort of the data aspect of sort of the technology space, but I mean, technology is so much broader than that. And so, you know, I guess just to say that I think it is on the table to think about technology broadly construed and to think about the technologies themselves and not just the data side of what comes out of technology. So I just want to make that explicit that I think yesterday in 20 minutes, he could only do so much, but today is really where we are intending to go broader. And so please, you know, think about, you know, technology broadly construed. And again, we'll get as much as we can on the table in 10 minutes. Okay, so please feel free, if you can raise your hand and then I'll just call on people and welcome some introductory thoughts. You can also like physically, yeah. Peter, do you want to start us off?
Sure, happy to kick us off. So I think you're right. I mean, to be honest, I think at one moment or another, I heard a lot of the kinds of things that I would have expected to come up, but I don't know that we really emphasized some of them in particular. So I'll maybe do that. One area, if we're trying to be bold and sort of look forward, I think that we touched on, but maybe deserves a little bit more emphasis, is the kind of technologies that really touch patients, if you will. And again, I really liked what we talked about yesterday, and I struggle with this too, of just calling them people. And increasingly the sort of shift, as we all know, is underway to, you know, more of that kind of empowerment of the individual to be able to actually be more at the center of their health, and really have more capability to be able to do a lot of the kinds of things that I think we currently live under still, you know, even with our current paradigm where we try to engage with patients, we often still look at it from the perspective of how do we engage with patients as opposed to really truly having it be patient-centered. And I think there is a lot of opportunity with technology, with the 21st Century Cures Act, and the sort of, you know, things that still are to be finalized in terms of rules and opportunities to really drive forward how we can actually create and realize a new era where that actually leads to, again, more empowerment, more capability, more transparency, more engagement, and even driving what it is people are doing for their own health. But it's also an area that is new, and so it's sorely in need of research. And I think that's why I wanted to emphasize it, because I think there's, you know, enormous need for developing the evidence for how do you do that well.
Great. Yeah, I mean, just sort of maybe a brief reflection on that, which is that, I mean, we all, you know, so the vast majority of the population has an incredibly powerful technology in their hands today, right? And so really thinking about sort of what is the model for taking the technology capabilities we have and having them become integrated in the way that we live healthier lives. And so it's, in some ways, it's less about the technology itself and much more about the way that we use it and how we use it to promote health. So, Eric.
Yeah, just building off of that, I completely agree that I think there's a need for more research, and kind of a key specific area within that is really engaging patients to determine sort of what the usability of digital tools are and really ways to improve them. So they're providing the value and benefit that patients need. Another thing I'd add as we're kind of coming through COVID, a lot of lessons learned around telehealth, which, you know, we've always kind of seen as a great way to increase equity. But I think one of the concerns that we want to be careful as we think about expanding telehealth more broadly that we're not leaving people behind in terms of broadband connectivity, but also in terms of accessibility for disabled individuals as well, and certainly limited English proficiency. So really making sure that we're doing it in a way that creates more options, doesn't pigeonhole people into telehealth if they need in-person care, and making it broadly applicable to all individuals.
Yeah. So I'm just going to pause briefly because it seems like there might be a little issue with the breakout room. And if we get kicked out, it sounds like they're going to ask us to. Okay, and we're back. Terrific. Eric, well, thank you so much for the comment. And I think our topic in some ways cross-cuts all the other topics that were addressed yesterday. And I think you're bringing up in particular some of the intersections with, digital health equity and how do we ensure that we are designing solutions that, that are going to be equitable and give people not necessarily the same access, but appropriate access given what they need and their personal circumstances. So that's a really important point. Sorry, I'm just going to do a time check too. I just was the agenda is a little bit confusing, but we have until 15 minutes after the hour. So we have about 45 minutes total in the discussion, and I'll try to just, do time checks along the way. Great, okay, so other sort of, big concepts that people felt, were missing, or ties, between concepts that weren't necessarily addressed yesterday. Okay, Eva and then Kathy.
Yes, just kind of building on the previous two comments. I won't repeat them, but I think a particular nuance of that is, and it's a piece of digital equity, and that is just simple access to broadband internet, whether that is personal access or regional, rural access. And my personal feeling for a long time now, given what we have known and also heard again yesterday about the size of the healthcare industry and the portion of our economy that it comprises, it seems like a huge lost opportunity for healthcare not to be taking a more active role in these more societal level decision-making processes that we need to go through. Why is it that we don't find it acceptable when people don't have power and water, but we do find it somehow acceptable that such a huge portion of our population does not have access to the basic tools required to thrive in society, i.e. the internet? And I think until healthcare starts taking the leadership role that it can, and I would argue should, in terms of our broader society on being not okay with that, then that problem is probably going to be really hard to resolve. But then the other thing that really struck me yesterday that I would love to have more conversation about it, and it was actually brought up in Dr. Hardiman's first set of comments, and she said, she referred to it as the emancipation from the dominant frame. Whose evidence do we consider to be real? And this is something I struggle with, and I think PCORI is perfectly positioned to wrestle with, and that is the need for rigorous evidence, yes, and also the need to value the kinds of evidence that are not what we have considered to be rigorous. And an example of that is a current project that I'm already participating in with my organization to address maternal health inequities. And there's a strong push on the consumer side to have doulas be much more prominent in the care provision, particularly for underserved and communities that experience significant inequities. And there is a need on the part of providers and health insurers to make sure that the care that we deliver, that we support and pay for is good quality. And so how do we resolve that tension to meet those very specific needs of populations and to create an evidence base that does not shut those communities out because of the very rigor that we're requiring that is just an impossible bar for them to reach. So how do we deal with that? And I think PCORI is a great organization that's well positioned to wrestle with those things and to maybe redefine what we call evidence. And to Dr. Hardiman's point, redefine what we consider real evidence.
Terrific. Kathy.
Yeah, I think I'll do this fairly rapid fire. So in terms of this idea of technology, it does require infrastructure. Full disclosure, my husband spent the last 5 years, including at the White House, figuring out how to get broadband everywhere in the country. There are maps that are available that can look at economic situations, financial, educational levels, broadband access, etc. Proposals, so this is specific, proposals to address technology issues should be accompanied by a technology access assessment. So who are you helping? It might be someone in a rural community. It could be someone who is in an impoverished part of a city. The second area where I think PCORI could make a big difference is we're still figuring out this hybrid model of care. The pandemic imposed it upon us, thankfully. It's the silver lining. But being able to study, for example, care that is delivered in the home, when is that best done? How is that accomplished? What makes sense in terms of the care that has to happen inside the walls of a facility? We hear so many stories of patients who love being cared for at home and are more activated. So could there be that understanding of patient activation that is enhanced by location of care? And then with respect to technology, I think PCORI has a big opportunity with respect to looking at artificial intelligence and being able to examine what is the ethical development, implementation, and surveillance of health-related artificial intelligence, because it could be an expansion of capacity, improvement of data, but it could also have unintended consequences. I'll stop there.
Terrific. And I think you just picked up on one of Peter's points in the chat. So again, just an invitation to also use the chat to throw out ideas. So terrific addition. Okay.
Yeah,
Deb, I don't want to put you on the spot, but anything? Oh, good.
No,
Go ahead,
I
Peter.
was just gonna ditto that last comment. I think that's exactly right. And then I just wanted to again put a plug in for, as we're talking about precision health, et cetera, including here, so much emphasis on the molecular omics, and I think not nearly enough on the the social determinants and all the other sort of factors that we know are so critical to health. And again, I think just a huge imbalance in the amount of research that's happening relative to the importance of that area of technology and data.
Great. Other thoughts, again, in sort of this big picture? I'm almost trying to sort of organize what we're talking about in some kind of a framework, because it's so vast, and I want to, I think part of our contribution could be to help frame this. And so it does feel like in some ways we're talking about, foundational components. So broadband might be an example. To my mind, interoperability of data, like of all types of data. It's just another one of these foundational components. We need better interoperability of data between medical and social care. We need better interoperability of data from sort of, social determinants all the way to the omics. So that again feels like in sort of this technology space, one of these perhaps, infrastructure, or I don't know what we want to call them, foundations. And then there's sort of these applications that are getting layered on top of it. So one is sort of the patient-facing tools, so tools that patients have access to. One of them is sort of care at home. Another is AI, though again, that can live in so many different places, but I think sort of this notion of AI-enabled applications that could be used, you know, for patients themselves, in surveillance, sort of public health use cases, or in clinical care use cases. So the need to sort of think about those applications and all the various sort of ethical, as well as, I think, you know, effectiveness, you know, of them. So anyway, this may be one way to start to organize the comments that we've come up with so far. But maybe let's, you know, go through and do a second round of additional, you know, additional concepts or ideas that we felt like didn't get discussed yet. Anything else that would be on your list, Kathy?
Mute. Too many buttons. I was the person who raised the question yesterday about cybersecurity incidents, and I realize it's a sensitive topic, but as maybe as an analogy that would help with the thinking. A lot of work's being done, has been done, is being done, looking at vaccine hesitancy. I think there's an opportunity to look at information sharing hesitancy, and particularly with respect to the cybersecurity risks. And I think we have a lot to learn from patients, not just the people who sign up, but I think we have to figure out some ways to better understand why someone would not sign up. And, you know, for one, I'm not there yet for signing up for the NIH database, because I've been under surveillance for identity theft for 8 years now, thanks to all of our data being stolen because of my husband's job. So, you know, we're going to have to overcome data sharing hesitancy.
Yes. All right. Let's see. I'm just doing the order that I saw hands: Eric, Peter, and then Eva.
And on the other side, but I completely agree with you. I think that's something we really need to get a handle on. But I think on the other side of it, I think for those who are willing to have their information shared, I think, you know, we've done a number of focus groups and other research to see, you know, that people with chronic conditions tend to have you know, obviously very concerned about their privacy and security, but have a different benefit risk analysis maybe than a healthier individual who, you know, really want to make sure that their information is useful for research, if not for them, for their children, or for other people who are inflicted with their condition. So I think there's a need to kind of focus on how do we make it easier for people in cases they want to, really thinking about what the informed consent may look like, making it easier to have information shared if they want it to be, but to really understand what that informed consent is. I mean, how many times have we, you know, scrolled down, clicked accept, and without reading anything, really trying to engage and leverage engage with patients and leverage their expertise to really make it as simple and understandable as possible, and not kind of rely on the ones that we've simply used for web forms and other things like that to really make it easier for people who want to, but certainly on the other side of it, doing a better job of protecting the sanctity of the data.
Great, Peter.
Yes. So I was just making a note here. I'll put it in there as well. I sort of mentioned this yesterday in a Q&A with Dr. Koshal, but I think there's an opportunity as well to think about how do we really redefine the practice paradigm to ensure that we not only are bringing better evidence to practice, but we're also generating evidence via practice, and do that in a way that, of course, balances all of the challenges of practice. And frankly, that's a big part of what, you know, many groups are talking about with regard to burnout and various other components. But I think what's being missed, and you heard it from her, as advanced as many of our organizations are trying to be in terms of creating learning health systems, this is a really, really difficult problem. And I think we've really got to think outside the box in terms of how do we ensure that our incentives are aligned, our technologies are capable, and we do it in a way that allows clinicians not to quit what they're trying to do in terms of actually making sure that we can actually have a learning health system and generate evidence through practice. I think that's an area sorely in need of work.
Yeah, it feels like we keep wrestling with, we don't want to be bound by the constraints of EHRs, yet we know they dominate today what happens and what can happen at scale. And so I think sort of trying to find a way out of that and targeting innovations that allow us to feel like the chassis, of EHRs can be used in a more sort of adaptable and supportive way. So maybe when we get to the opportunities and disruptors, we can also come back to that, because it just seems like we could really be helpful if we can give a sense for what might help us get out of that bind. Eva.
Yeah, I love this whole line of thinking, and it's actually brought up a few ideas on my part. And it's made me think about the whole issue of trust in healthcare, and that certainly encompasses these areas. But I think PCORI, an interesting line of inquiry for PCORI might be to better understand those trust issues. I think we've probably just scratched the surface. And of course, there's also in the equity space, the traditional or the referencing to the historic very good reasons for particularly Black Americans to distrust the healthcare system. And those are real. And also what I feel like we've done in the absence of better and more complete information is to make certain assumptions. And an example of that, I just actually learned last week from one of my own colleagues, and that is there's been an awful lot of assumption about vaccine hesitancy on the part of underserved populations, some of which of course probably is true, but her point was that that it is less true than one might think, and as a result, those populations are not being vaccinated at the rates that we would hope, in spite of, as in DC, there's been actual explicit preference given to certain zip codes, and still that has made zero impact on the inequity in vaccine rates. And my coworker, who is Black herself, spent a whole day trying to get her father vaccinated, and he was actually turned away from a pharmacy. So there is the racism component that was brought up, but I think this better understanding the actual distrust for all populations, but particularly people of color, I think is really important, so that we don't make false assumptions. And I'm connected to the Latino population here in DC, and the same is true there. They are not hesitant to get vaccines. They are actively seeking them. And the very methods, primarily technology, that are being used to try to get vaccines out quickly have shut them out, because they also work shift work that makes them not be able to stop and get access to the 1,500 vaccines released that day at the moment they're released. So I think we really need to better understand those issues. That made me think then about, and part of what Kathleen said made me think about the sharing, not just of certain data, but also when we get into understanding social needs and race and ethnicity. If we ever get to the point of actually defining race and ethnicity and collecting that data from patients, are they going to be hesitant to give us that information? I think probably a lot will be, and there has been work done already by ARC and others on how to ask about those things, but understanding the fear of that and addressing some of the things that Kathleen mentioned, I think can get us further down that road. And that made me think about really figuring out how do we create a system that is based on people's strengths and that really leverages their strengths to engage them in their care and meeting or achieving better health can be a much better system than our current system, which is very needs driven. It's very paternalistic, in spite of the good work done by PCORI and others. And it's a healthcare system. And so I think that's a radical change that can come about. The final thing I'll offer is just the sheer cost of technology. I work with health plans, many of whom are very advanced in their information sharing because they're provider and payer aligned systems. But what they've found is that the promise of decreasing costs that technology has offered have not come to pass. In fact, that has increased costs. And just looking at a specific slice, the quality world, it is much cheaper for a health plan to hire an army of data collection, an army of nurses to collect data from charts than it is to pay the licensing fees for the four information exchange organizations that they need to get access to all the information they need to populate their quality measures. So technology, yes, it's necessary, and it comes with a huge cost, and that is not being offset by other efficiencies. And so how do we deal with that? So I know that PCORI has to tread lightly on that cost issue, but it sounds like that's been opened up a little bit with the reauthorization. And I wonder if that's a place that would be a sweet spot for PCORI.
Great. I think in the interest of time, I do want to transition us to the next question, which I put in the chat, but Bev, I wanted to give you a chance to weigh in on this last question before we transition.
So I'm going to try to transition for you as well.
Even better.
Just a comment about Peter's point about really using the EHR to generate evidence for practice. I think as we could go forward and do this so much more effectively, providing useful, unblinded data across clinicians in a practice. And I think if it was anchored more in terms of outcomes of care and not just patient experience, and to do this in partnership with patients and families, that would be a great research agenda that would drive improvement fast. So on to what I thought were opportunities and disruptors. There were two that I kept thinking about last night. One is open notes, which we've had for a number of years, and the open notes people that started this are terrific and believe in partnership. But there needs to be a much more accountable system. I get my type 1 diabetes care from a very well-known tertiary health system, and I have yet, and they say they have been using open notes for 3 or 4 years. I have yet to see it come through that process, and even challenged my physician about it. I can work around it. I'm an insider in healthcare, but we need patients at the core of this, designing a research agenda as this greatly expands with the CARE Acts. And I think PCORI could set the real culture of research related to open notes and the use of my notes, which to me may be a way that patients begin to take more responsibility for their health and healthcare. And just looking at people who do that, the impact on their lives and their health. And I'll mention telehealth. I'd love to come back to that discussion because again, it exploded in the last year, but we didn't do it in partnership with patients. And so they should be part of teaching clinicians how to build trust in this virtual way, to really build a research agenda and maybe tie it to accreditation for clinician practice for virtual telehealth. So I'd love to spend more time, but I'd love to hear what others have to say. Thank you.
Yeah, I might just pick up on that. I mean, when I think about, what could really look different, 5-ish years from now, I mean, I think, the ability of technology to surveil and infer things about our lives, it's already here. And sort of the applications of that for health, to my mind, are, about to explode. And the ability to turn natural language into structured information. So when I think about what could be known about me because I have, Amazon devices in my house, because I have my phone with me, again, it's going to be the good and the bad, but I think that is both, again, a disruptor and an opportunity to really think about what could happen in terms of, patient-centered health at scale. And so again, there may be an opportunity there for PCORI to get a little bit ahead, because I don't think it's been cracked open yet, but it's something for me that's very much on my radar in this technology space. All right, who else wants to jump in on disruptors and opportunities? All right, Kathy. Oops.
There we go.
Not quite unmuted. There you go.
So this might be more disruption than PCORI can stand, but they're big, they're strong. I have always been struck by the amount of time that investigators and their teams spend in writing grants. So the one non-renewable resource is time. Once it's passed, it's gone. And I think that where I'm coming from on this is thinking about Mackenzie Scott, formerly Jeff Bezos' wife, who created gave away $6 billion with a B to organizations based on the merits of their organization. They did not apply for anything. And is that a space where PCORI could identify truly awards to investigators and to organizations that are doing the kind of work that we are talking about? She also has it that you report back. How many hours do most of you spend reporting back to the funder? The reports for her, 3 pages. Thank you very much. Here's what we did with the money that we received. And so I think there is the potential for a tranche of money that comes with fewer strings attached. And you might then get some really interesting, particularly community organizations involved.
Great. Well, be still my heart, but let's keep going. And again, let's get a broad range of ideas on the sort of disruptors and opportunities. Peter, then Eric.
So I wanted to go back to something I also said yesterday, which is there's, I think, enormous opportunity, but also obstacles in the current persistent disconnect between the ways in which our operational sort of elements of the health system invest in and otherwise enable quality improvement and other kinds of activities versus what I think a lot of us in more the health services research sort of domain think of when we're trying to do that, or those of us that are working to create learning health systems, et cetera. It's something that I consistently face headwinds with, and a lot of it is about, translating priorities and being able to make sure that we're sort of using the language that makes sense to both sides, and that it's actually seen by the health system apparatus as something that is value add given, their current priorities, et cetera. So I think it actually picks up to some extent on Kathy's comments around the bureaucratic obstacles and those kinds of issues too, because a lot of what drives their activities, and even Ava was referring to this in terms of, sending out an army of people to collect certain data elements to be able to put it in a particular report, to what end, right? I mean, is it really leading to the kinds of improvements? And on the contrary, if we took all that time and resource and energy and money and the like, and actually focused it on things that were going to improve outcomes, wouldn't we be better off? And isn't there a way to more properly kind of align the incentives and therefore the connections between what we traditionally think of as the academy and the operations to really be able to enable this? I would love to see mechanisms that actually require that connection between sort of the health system apparatus and the academy Tomorrow I'm going to be on the National Advisory Council meeting for ARC, and I'm going to be saying something very similar to this. I think there are multiple agencies that need to be thinking about how do they do that. It doesn't take a lot of money. It just takes the right sort of focus to be able to sort of steer people in a particular direction. And I think PCORI could help with that.
Yeah, and guidance on how to do that well. I feel like, there's so much know-how that's being developed at different organizations that then, haven't figured out how to translate.
Yeah, they're like the exceptions to the rule. Yep.
Yeah, exactly.
So a couple things. One, completely stating the obvious here, admittedly, COVID is the great disruptor for everything, more than we've ever been disrupted in our lives. And I think that as we, looking at just telehealth as an example, one of the biggest barriers to uptake of telehealth had been provider hesitancy, but being forced into that paradigm kind of removed any of that hesitancy. So now what are we doing to learn lessons from what we've been through over the last year? I think will be really important, not just on these topics, but really everything as part of this work stream, I think. Beverly, I love that idea of looking at how this might be leveraged through accreditation. I might follow up with you on that one. I really do think that, lessons learned and looking for silver linings throughout this, I think is a key thing that PCORI can really be looking at. The other one, I think another big disruptor is simply the cost of healthcare. We heard yesterday in the presentation, and we've heard repeatedly about how close we may be to Medicare insolvency. What are we doing to really address that issue? I think looking at technology, I think there's a couple kind of key areas where technology can be a driver there. As PCORI, to the point that was raised earlier, kind of has the door open now to look a little bit more at the cost of care and the financial toxicity and burdens on patients. How can we leverage technology to get a better handle on what the actual burdens are on patients? And how can we use technology to alleviate that as well? We've heard a lot about consumerism in healthcare. I think, I think probably most people on here can agree that, a lot of that is probably can be overblown in terms of how much consumerism is really allowed in healthcare. So what are we doing to create those tools that if we are talking about, allowing people to shop for the best deal, I think was a big emphasis of the last administration. It's not an issue that's going to go away. How do we create those tools to make patients informed consumers? Because you can't have a free market without any access to information that you need to make your best decisions. So what tools exist or could be created to really help people leverage those opportunities where they do exist?
Eva, did you have your hand?
Yeah, just a quick follow-up to what Eric just said. Yes, absolutely. And I think to put a specific question to part of what he said is, what is the specific information that patients, consumers, people find most useful for their health, both related to cost and related to their own care? I think those are unanswered questions that can really help speed adoption of technologies and also reduce cost. And then the other thing that Peter's comment made me think of is this notion of information sharing between our healthcare system and public health, which, historically they've been, for the most part, divorced in our healthcare system, and certainly COVID has highlighted the need for that better sharing. But any effort to drive a health system certainly also demands that as well.
All right, well, maybe I'll move us into major challenges and obstacles to advancing progress. They've already come up a bit, but just to spend a little bit of time thinking about sort of what are the key issues that, if we were saying what's going to prevent us from realizing some of these opportunities. I am curious in particular when we think about, I very much share the sense that we've learned so much from COVID, and this will really be letting a crisis go to waste if we don't sort of think about what we want to do differently. But like, what's standing in our way of doing that? And, I do see that there's almost a mentality of when we get back to. So I'm sort of I'm very curious in particular, sort of how do we break that mentality, and how do we sort of think productively about how to take the best parts of what's worked and but also fix the parts that haven't because we had to move so quickly. Kathy, go ahead.
So I'm going to challenge the group to explain to me, perhaps, why we would think about adding additional criteria for accreditation or for inclusion. Essentially, what my brain says when I hear that is that sounds like more paperwork. It sounds like more checking of boxes. And it therefore sounds like I'm going to need to hire more people to do what is something that is not clinical, right at the bedside work. So an obstacle, I will be your obstacle unless you can directly show me what work you are taking away, and therefore I can do this added work, but ideally the net needs to be less. Example in the quality field, physicians are required to be re-credentialed every 4 years by hospitals. Every 2 years. We have argued that should be moved out to every 4 years to reduce burden. What would help with that? We now have in-practice assessments that are local, that are focused, that make sense for my practice. So let's make a deal to, we're not saying throw out the intent, but do it differently. So I think we have, everything has to be weighed. It's like Cass Sunstein's work when he was in the Obama administration, where they looked at all the regulations and said what might have been good at the onset, but what is no longer delivering value and should be removed.
Removing regulations is perhaps even harder than passing new ones. But yes, I think so that makes a lot of sense.
Well, and just briefly, the last administration, right before they left, and I don't think it will go into effect, said, we're going to put a time limit on every single regulation, and it will blow up and have to be replaced on a certain frequency. That's not, in my view, the right answer either. So I'll just leave it at that, and I'm really interested in what people have to say.
Yeah, but it sounds like maybe the overall takeaway is sort of revisiting our current policy framework and figuring out which ones, some sort of systematic assessment of which ones really have, you know, sort of transitioned from helpful to burdensome, so that we have a sense of which ones we could target. Beverly, did you want to jump in?
Sure, thanks. I was thinking about to do something different, and in the last 30 years when we've been doing this work to build partnerships with patients and families, often the resistance is it'll cost too much if we bring them to the table with us. And what we have found repeatedly is that they want things that cost less, that when we rely on our clinicians and our administrative staff and frontline staff, it usually costs more. And what I was thinking in this conversation, Eva made me think of the agricultural extension that was nowhere on my horizon at all. So that was fun to think about. But really how PCORI has changed the culture in the research community in 10 years. What about really creating a way for patients and families to say what we should be doing different, you know, redesign the healthcare system, not just one hospital and health system at a time, but what would it look like? Is there a way that PCORI could convene that over in a lot of different ways to reimagine healthcare, really use all the best principles of innovation driven by them that would promote health, and see where that goes, and that it might be tied with a research agenda or whatever. But I think hearing from people that have used the healthcare system and see both its strengths and its areas for improvement and the need to save dollars at the same time. So just a thought.
And also now the technology to be able to have patients, families articulate what they want the role of technology to be in all of that, I think is also really important, because that conversation would look really different today than it would have even 10 years ago. So I think to really get their perspectives on our, yeah, absolutely. Because I think there's, that's terrific. I might just jump in with one more challenge or barrier to get out there, which is that, I think as we're working more and more with data, we're realizing that even the same piece of data can mean different things to different people. And I think we really need to sort of come up with a better framework for sort of understanding. It's not quite data quality, but it's almost data context. And I think that becomes really important, because you can show, Open Notes is a great example of that in sort of a broader sense of, when clinicians are changing how they write their notes because of Open Notes, and that's, probably a good thing. But I think that there's also open questions about, how, again, what does a note mean when it's being read by a non-clinician? And so I think this whole concept of sort of data context and then how do we use data for all these different purposes, to me feels like sort of an obstacle that we haven't really figured out how to tackle. I think we know how to move a core set of clinical data around from place to place, but that's really only the tip of the iceberg when we really think about what we need to do with data to achieve patient-centered care. Sorry, Peter, I cut you off. I just wanted to.
No, that's great. I'll just pick up where you left off. I think you're exactly right. So just to take that a step further, with the health information exchange and the kinds of things that we do there, it's still very much driven by and promoted by and actually exists for health systems still. And even Open Notes, even these things, which I applaud, it's really about still the control is still very much at the level of the health system. It isn't really a shared record per se. It's still very much controlled by the health system. And so until we change that, right, until that sort of fundamental paradigm shifts, then we're going to have these obstacles, because they sort of keep coming up in terms of, well, sure, we'd love to do that, but it's going to cause a problem here and a problem there, and we're just really trying to keep the doors open, and it's already so open for everyone, et cetera, et cetera. So I think that's an obstacle.
Julia, can I add one thing, which is that the way that health systems are sometimes held accountable is through their not-for-profit status. And wouldn't it be interesting to be able to look at and do comparative work to understand what are some of the best, I choose that word with some caution, community needs assessments and implementations, because it can be all over the map, but at some point there may need to be almost a minimum standard for not just what the assessment contains, but the actions that result from those community needs. And right now it can be anything a health system wants or says it can tie to a community need, but the community may say that has nothing to do with what we want. So.
Great. So I think we're coming down to our last few minutes here, though. I have to admit, Asia, I don't know if you can just chime in, like what happens at 15 after the hour, because I think there's a gap before the next event. So anyway, I'm not sure if we have a few more minutes to keep talking after that.
Yes, so there is one more question that we want to get through. So basically in the last 10 minutes of the time we have, I'm just going to show you all the summary slides I put together so that we can present those. I can send those to be presented at 12:45. So as just 10 minutes at the end of our conversation to make sure everything looks great.
Okay, so we have another half an hour to sort of summarize and wrap up, is what you're saying?
I just checked and it looks like we will start to summarize at 12:20 if that's okay. I realize that puts us at like 8 minutes for the last question.
No, that's fine. I think we can, I mean, we've talked about many of the topics already, but I do think it's nice in our final 8 minutes to sort of come back to this, you know, what else would it take, and sort of anything else you haven't had a chance to raise. So I think on top of my list is, I mean, I just keep coming back to sort of what are the technologies that are used every day at scale. And you know, I love that, you know, maybe it's again such a pipe dream, but you know, could PCORI partner with, you know, Amazon, Google, Facebook? I mean, I know these are not our favorite companies all the time, but like they exist at a level of scale that is so different than the idea of like a single study that gives a patient a single purpose technology and then studies it. And so I just continue to want to think about, you know, where are there partnerships that achieve scale, where they could make such a small change, you know, to what they do in a way that could, you know, have a vast impact, you know, almost overnight. So I don't know, I guess I just really encourage, you know, unusual partnerships where we may not be thinking about, you know, ways to advance health, but to leverage, you know, solutions that exist at scale and try to see where there may be ways that we could sort of take something that we don't think of as a health platform, but modify it in a very slight way that could have, you know, large health benefits. I mean, even just in my Facebook feed, you know, seeing how much messaging around vaccines, like that's, you know, that's a pretty incredible change that probably wouldn't have existed 5 years ago. So then what's like that makes sense for the next 5 years?
Julia, I'm wondering with that idea, you know, our whole patient experience system is based on organization by organization, and sadly it doesn't really get at the patient is really an active decision maker in their own healthcare, and that people really listen to them. And what if there was this, you know, national partnership that really gathered more perspectives from patients and families about really being engaged in their healthcare and planning in their health and healthcare, that brought together data that would help maybe inform the system and the real change that needs to happen. I just think we put a lot of money into it and we're not always asking the right questions. So that might be an interesting way to partner with Google or Amazon or something like that.
And I'll just add that
Right.
PCORI is uniquely situated to be able to lead those efforts. Certainly, you know, as they think about any of their research funding that may be related to the deployment of technology, I'm just continuing the work that they've done to ensure that patients are a part of any applications that come in.
You know, I'll mention one other thing that I think is just on the horizon, but starting to take off, which is we're seeing more and more parallel technology use, even among healthcare providers, sort of outside of the traditional electronic medical record, of messaging apps and various things, some of which are becoming pseudo-official in terms of being sort of hosted by their health systems so that they sort of have permission to use these things to talk about patient care, but then it doesn't become part of the record. So there's these additional sort of silos of data around what's actually happening that are being created in part because of usability issues and concerns around legalities and various other ones. And yet it's moving us further away from where I think we need to be going, which is actually this, you know, more sort of common collection of information that then can allow us to learn and be able to improve our health system. And I don't know if you guys are experiencing that, but just as another example, you know, when that happens, then we don't have access to it as researchers either, because it's sort of off in this other area. I have to imagine there's very similar kinds of issues with, you know, other increasingly ubiquitous technologies. And so I think, I'm not sure exactly what I'm asking for, but some kind of a landscape assessment of, you know, those kinds of resources and information sources, I think would be part of what I would want to see us kind of dive into in terms of what do we really need to be doing? Because, and as I'll end with this, you've said this in various ways, Julia, it's like, if these things are happening anyway, and there's people using these, then great. We don't need to, it's like in, landscaping, where you just let people wear the path and then you put the sidewalk down. Like, good, let's use those technologies. I just think there's a little bit of opportunity there, rather than trying to invent something new. As what are people voting with their feet on?
Literally.
All right, any last few comments or reflections before we sort of try to package this and get ready for the report out?
Yeah, I really liked that Kathleen brought up the community health needs assessment. I mean, it's a requirement, and yet I think it's often a check the box that falls by the wayside and really does nothing. But there are some exceptions to that, of places that are doing that well. And Kaiser Permanente actually has a very robust online kind of version of that. And I think that's a great opportunity to take something that already exists, that some are already using technology to drive, and figure out, how do we take that the next step and scale and spread it across the nation, knowing that everyone, or all the health systems that are, I believe, nonprofit, are required to do that. So let's do that. And I think, and I put in the comment also, I've been very frustrated that there's really no way to quantify in a standard fashion what these kinds of nonprofit, tax deductible donations or charitable efforts. So there's no way to quantify that in a standard fashion in terms of the impact. And so if we did this with the CHNAs, then that would maybe be a step in that direction that could help us better understand both the value of those investments and perhaps increase the value, because there's probably some of those investments may not be having the impact that they should be, given the tax status. And I would include our members in that, given that they're nonprofits. So.
Yeah, sort of this interesting theme of sort of revisiting old structures that exist in a new context, that we know that sort of, we've never really thought about community, these community needs assessment in sort of like the tech-enabled world. And so I'm intrigued by this idea of sort of retooling and readapting those in a way that feel much more relevant to today's circumstances and what we need to know.
Yeah, just a quick comment. I think we could build on some lessons learned there in the state needs assessments. There are already families that are required to be part of Title V for maternal infant health, and they've done that really well. And some of that is also true for HIV and AIDS. So I think we could connect those two at the state level and at the community level, and really have a broader part of the population involved in that work.
It just feels like there are these dots that are not being connected. So right now, every state has to submit a new health tech plan to Medicaid as part of their sort of legacy of the meaningful use funding. And so, again, that's going to happen in a silo. There's not going to be patient voices involved in that. And it's just, I don't know, again, it just strikes me as PCORI might be uniquely positioned to sort of see these different things that need to exist and at least articulate a framework for how to start to bring them together, because it just feels like there are going to be opportunities that are missed if they sort of continue to have their blinders on in terms of, what percent of hospitals have EHRs, like every state's going to report that out, but like that's actually not really the most meaningful measure. So anyway.
Yeah, and I would add to that, and this is not usually the case, but there are some areas where Medicaid is actually leading the way on innovation, and the commercial, and I'm speaking from the insurer perspective, the commercial areas are kind of lagging, and one of them is maternal health. And you can kind of there are some reasons behind that. I won't say that they're good or bad or otherwise, but there's not the drivers for commercial insurers to do some of the things that you were just referencing that exist for Medicaid. And so how might PCORI, because there's a lot of the commercial insurers that are part of PCORI and the PCORI payer form, how could PCORI convene all payers and others too, to really define how can we make progress in some of these areas that we've not traditionally paid much attention to, but they are relevant to us.
Okay, well, I think we should probably transition. So at this point, Asia, can you just, do I hand it over to you or to you and Kathy, or what's our next charge?
Yes, I was just about to message Kathy back because I will be sharing the slides for all of us to review and just make sure that I described everything in a way that everyone is comfortable with. So let me just, and apologies if I missed anything. They told me ideally 2 to 3 bullets, but you know, the conversation was just great. Of course, everything is being recorded, so we will have more formal notes to share later on. But these are the highlights that I wrote for the first question. If anything has anything to add or wants me to change the wording, I will take no offense.
So I'm almost thinking, should we go through all 4 of them? Because we did sort of, we had some fluidity in our responses to the 4.
It's a good idea.
Yep, that sounds good. So Asia, maybe just go down to the next slide 12, and then that was their next summary for question 2. Okay, great.
Under opportunities, I think it would be inferences as opposed to interferences.
Oh, I am so
I mean, it could interfere with our lives, but
that's true. Disruptor and opportunity, yes.
Yeah, maybe another way of, it's sort of the second bullet on opportunities, but aligning incentives, but it was also sort of a revisiting of the policy, relevance and, yeah.
sort of the return or the value, the value return on investment of existing regulations.
So yeah, revisiting, why don't we say, value of existing regulations. Yeah. Kathy, you can talk to this maybe when you report out.
Yeah.
I think the list of disruptors is probably more a list of challenges than they are disruptors.
Yeah.
Should I move on?
Yeah, I think questions 2 and 3, are so closely related. So anyway, Kathy, you can think about how you want to split how you talk about questions 2 and 3. Maybe go down to slide 3 and then how we want to split.
Yes, I did see some synergy between the 2 conversations.
Yeah.
Yeah, the first bullet I would say is new requirements will be encounter resistance. Unless the overall burden is reduced.
Right. Unless they're offset or they bring additional value over and above.
Yeah.
Right. Absolutely.
Yeah, they could bring efficiencies as well, structured correctly.
Right. And I think it may need kind of a word like immediate or something, because that was the promise of EHRs, and that promise has not really resulted in that reduction in burden.
So immediate and measurable burden reduction. That otherwise, you know, if you tell me to wait for 10 years, I'm pretty good at delayed gratification, but maybe not that long.
Sorry, is this right?
And I would say immediately and measurably reduce.
Okay, measurably, that makes sense.
Lack of minimum standards, that one is really community needs assessments. It's not so much the communities, but it's the needs assessment.
Well, again, I would just try to and focus that on, you know, sort of you know, with technology, because I think the community needs assessment, you know, for, I guess, in general, but especially for our topic, you know, with a focus on technology or something.
Yep. And it's the return. It's really, well, I can speak to it and I know it'll be recorded, but it's really that a huge amount of money is not collected in taxes, but how the community needs assessments lead to actions that we would all value is the issue.
Mm-hmm.
Not to throw another one out there, but I think it's probably a kind of sub-bullet under data quality. I think there's a very real concern about implicit, or in many cases explicit, bias within our data and algorithms. I think that's going to present a challenge as well.
And what we need is,
and maybe on that point too is it's not really data quality versus data context, but it's both. So it's improving data quality and data context. Yeah.
And I'm wondering on the, sorry to go back to the community needs assessment one, but I'm wondering if it's a little clearer to say a lack of standardized formats or
standardized requirements.
Yes, a lack of standardized requirements and application of community needs assessments.
Yeah. All right, should go to our last slide just because it looks like we have 5 minutes.
Yes. Yeah. Someone might say we're already doing the first, and that's what PCORI's been doing in its first 10 years. So is there a way we can make that gathering the perspectives of patients who receive care using technology? You know, because again, we're the technology group.
So if you wanted to there, I think to be very specific about telehealth implementation and the accreditation of physicians to practice in this way, and the research related to telehealth, I would do it with open notes. And I would do it with the broadband implementation.
I think telehealth, yes. I do think it may be a bit broader than that as well. I think there's also a need for more patient engagement in the development of digital tools like wearables. I think would be another area where patient engagement would be beneficial.
So I would list them specifically so they
Yep.
would get the benefit of that, not to, so, you know, it's the expansion of open notes, which is going to happen because of the law, but whether it's done well. And wearables, I think, is a great idea.
And I'd say use of wearables.
Mm-hmm. I think use and design too. I think there's room for improvement in the design of them.
Yes. Because the design is sometimes the obstacle that results in disparities.
Yep.
Is this another slide where we, I'm trying to read them and not add unnecessarily, but do we need to be also articulating here the, to have a measurable impact on health and healthcare, again, the connection between the, for lack of a better word, the academy and the operational components. Is that captured elsewhere already, or should we put that here?
It's not.
No, I
it
think let's
needs to be here.
Put that here.
Yes.
Yeah.
Okay. Sorry, can you repeat that?
So we need to encourage activities that strengthen the connection between the academy and how would you phrase
operations
and health systems. Okay.
Yeah. And align incentives for enabling a learning health system.
Yeah.
And maybe incentives, given what we're doing, is not the right word. Align technologies and incentives for a learning health system.
Okay, sorry,
You
we're
know,
about to get kicked out in like 10 seconds, so I just want to
I
make sure.
would just get rid of that last phrase, and what I'll do, no,
Oh, sorry.
Not the whole thing, just the last little bit.
after the
Just the last, yeah.
Okay.
And
Perfect.
then what I'll do is I'll ask the group to comment on things that either have been left out or that merit consideration by the whole group. That's going to be our bailout clause.
Perfect. This was fun, guys.
Thank you both, Kathy and Asia. Yeah, you did a
Thank you,
great
Julia.
job.
Thank you so much for clarifying everything.
Well done.
Yeah, boy, what an amazing session.
Agreed.
I was a little nervous about moderating such a vast topic, but you guys made it easy.
Great job, Julia. Thank you. You had the tough job.
On PCORI's behalf, I just want to thank you all again. It really was incredible to listen to, and I appreciate all of your input and time. I'm looking at the wrong screen, so apologies for that. Keeping track of where my camera is versus what I'm looking at.
Right. Okay. I guess, do we leave the room or do we wait to be kicked out?
So I just reached out to the controller of the rooms. She told me to tell me when our discussion was done. So I believe she will be taking things from there. So
Asia, maybe then if we have time on that last slide, I think just the idea of pursuing partnerships with, you know, technologies that exist at scale. I think that was the other sort of big idea. So if it's easy to add that to that slide 4, question 4.
Yes. Sort of the win-win.
So encouraging activities as an extension of this, or?
Oh, new bullet.
No, sorry, one more bullet. I know we're going a little over, but I think. So I'd say something like develop partnerships with technology platforms that exist at scale to advance health or something.
Yeah.
Okay. Right. I will send out those slides.
And then Asia, will you be controlling the slides, or will, how does that work?
So I believe Ariana will be controlling those slides. So whenever you want to go to a next slide, you can just tell her next.
Next slide.
Yes, next slide. It's that easy.
Great. Maybe while we're waiting to get kicked out, can we scroll through the chat and just see if there's anything people want highlighted that is the sort of idea of the extension service is intriguing. Open notes we've got. I think I'll start out with trust because yeah, this idea of the bidirectionality of generating and using evidence. I think that's a key theme.
Happy to speak to that if it doesn't otherwise flow naturally.
Yeah, no, that would be great. Yeah. It might have been Eva, I think, that made the comment that we need to know not just what technology works, but how it works and for whom it works. So sort of this notion of personalized understanding of technology is how I heard that. So maybe put a pin in that if I don't include it in the remarks. Oh, and was it Beverly or maybe Eva talked about a system that's based on people's strengths? So I think there are a few like sort of overarching themes here because we oftentimes talk about weaknesses, which is not very attractive or appealing. But systems that start from strengths might promote engagement.
Yeah, and I think Peter made the initial comment about, you know, we've made headway on being more patient-centered, but still a lot of, even in our patient-centeredness, we still are kind of driving toward what the health system needs. And so if we flip that and focus more on people's strengths and how can we leverage those for better health, then we create a system that is more tailored, more efficient, and more affordable, as well as more effective and patient-centered.
Yeah, I like that. Because otherwise it could just sound impossible. So big a lift, I'm just going to check out. I'm not going to do anything. We keep not getting kicked out. It means that other people are going over time.
So I reached out and I think we're waiting on one group. Apparently we can only close them all out at once. So I already sent in the slides, but I can also, if you want, pull them up just so we can go over talking points. Or
is this a good moment to maybe take a few minutes? Are we starting up again right at 12:45?
Yes.
I'm going to take a bio break.
Yes,
Same.
Understandable.
You saw me drinking coffee.
All right. Thanks, everyone.
Thank you, guys.
Thank you.